Hi everyone, Dr. DeFelice here, and today we're going to be talking about systematic reviews and meta-analyses. So by the end of this module, you will be familiar with the difference between systematic reviews and meta-analyses, applying the PICO format to a systematic review with meta-analysis, evaluating the validity, the concept of heterogeneity, and interpreting a forest plot. So systematic reviews and meta-analyses are two different things. A systematic review is a planned, comprehensive, and reproducible summary of the research results on the same topic. Advantages to looking at a systematic review versus just a single study are that the possibility of bias is reduced by the planned and systemic nature, and validity can be verified because the results are reproducible. Now, a meta-analysis is a statistically pooled result of multiple related studies into a single summary outcome measure. And an advantage of a meta-analysis is that the precision of the treatment effect estimate is increased by the overall larger sample size and the greater statistical power. There can be a systematic review with a meta-analysis, which we will look at one today. And the well-performed systematic review with meta-analysis is the most useful clinically. So as you can see here, yes, a systematic review can stand on its own. A meta-analysis can stand on its own, but you can also have a systematic review with a meta-analysis. And when you're writing a systematic review with a meta-analysis, there are some very defined steps that you need to take. And the first thing, whenever you're doing any sort of a research question, is to define your study question. When we're looking at systematic reviews, as I'm sure you have done before, you have to define your search strategy. This is before you start searching. You also have to define the eligibility criteria. Which articles are you going to include in your systematic review? Which are you not going to review, and why? So you have to come up with a criteria for why you would exclude or include certain articles in your review. Then after all of that, you would search for the abstracts by keyword. You would go through and screen your abstracts. And then you would check full text articles for eligibility, right? Then you go through, you read the whole article, and you see whether it meets the inclusion or exclusion criteria. You take out the information. In a systematic review, you would summarize the findings. In a meta-analysis, you need to analyze the findings. And in a systematic review with meta-analysis, you need to analyze and summarize your findings. And then you write it up and you report it out. So we have a clinical scenario here. We have a 43-year-old woman that comes into the office with unremitting chronic neck and shoulder pain. Despite multiple treatment modalities, she reports no lasting relief from the pain, and she finds her quality of life is substantially impaired. She wants to know if perhaps cannabis can help alleviate her neck pain. She schedules another appointment, and the attending physician asks you to do some research and report back. So the very first thing that you have to do is you form your PICO question. Remember, P is patient, I intervention exposure, C comparison intervention exposure, O outcome, and T is your type of clinical question being considered. So when we look for our PICO question, we're going to look for patients with chronic pain. We could say middle-aged women with chronic pain. You can get more and more specific if that's the information that you're looking for. Right now, we're just going to look for patients with chronic pain. The intervention is cannabinoids. We'll see the placebo is, or the comparison is a placebo. Improvement in pain symptoms would be our outcome. And the type of clinical question that we are searching is a therapy question. And specifically right now, we're looking at systematic review with meta-analysis. So that's what we're looking for, that answers the question, among patients with chronic pain, do cannabinoids versus placebo improve pain symptoms? And so we found this article called Cannabinoids for Medical Use, a Systematic Review and Meta-Analysis. And this is found in the Journal of the American Medical Association in 2015. You can see the citation down there. So in our abstract, we see the importance is that cannabis and cannabinoid drugs are widely used to treat disease or alleviate symptoms, but their efficacy for specific indications is not clear. And so their objective was to conduct a systematic review of the benefits and adverse events of cannabinoids. So we found our article. After we found our article, it's time to assess validity or risk of bias, assess the results, and assess for applicability to our patient. So the first thing we do is we assess validity, and remember, let's go back to look at this risk of bias pyramid. Remember, the risk of bias goes down as you go up the pyramid, and the very tippy top, we have our randomized controlled double-blind studies, but at the very, very tippy top, our gold standard would be up here, and it would be systematic reviews of randomized controlled double-blind studies, because remember that one of the advantages of looking at a systematic review is that the risk of bias goes down because of the sheer volume that's being analyzed. So we found our systematic review, and we want to see the types of studies that are in the systematic review that we are looking at. And remember, the top of our pyramid here are RCTs. And right here, the study eligibility criteria, RCTs, right? They are comparing cannabinoids with usual care, placebo, or no treatment. They also address right down here that on some indications, no randomized controlled trials were available. So instead, they used non-randomized studies, including uncontrolled studies like case series, which is one of the observational studies that we talked about. So it's a combination. I think that mostly they used randomized controlled trials. So we've got a bunch of questions that we need to ask for assessing the validity for systematic reviews. We want to ask, did the review explicitly address a sensible clinical question? And to answer that question, you have to determine the author's PICO question. Another question that we'd like to ask is, was the search for relevant studies detailed and exhaustive? When we're answering that question, we want to look for a description in our journal article of a computerized search or other methods of obtaining articles. You want to look to see if they did any hand searching, any searching of the gray literature, which is literature that's not been published. It could be theses or doctoral dissertations. Were the primary studies of high methodologic quality is the next question we'd like to ask. And to answer that question, we're going to look for an assessment of the methodological quality of the studies that were included in the systematic review. We also want to ask, were selection and assessments of studies reproducible, right? So is it just one person making the decision and based on their gut, or do we have kind of at least two authors evaluating the quality of the included studies? Those are questions we want to ask. So we'll start with the first one. Let's determine the author's PICO question. So we can go through and read some parts of this article, some parts that may be helpful when we're trying to figure out what the author's PICO question is right down here where they say the aim of this systematic review was to evaluate the evidence for the benefits and adverse events of medical cannabinoids across a broad range of indications. We can also see something like, oh, this looks like a comparison here, either usual care, placebo, or no treatment, where we have our intervention as the cannabinoids, right? What are the indications? They looked for many, many indications. Of interest to us is chronic pain. Yeah. And so then we go and we look for what is the author's PICO question. So in here, they had in patients with nausea and vomiting due to chemotherapy, depressed appetite, and HIV/AIDS, chronic pain, spasticity, anxiety, depression, sleep disorder. In patients with these indications, the intervention cannabinoids versus usual care, placebo, or no treatment, the outcomes they're looking for are benefits or adverse events. And the type of clinical question being answered is being asked is a therapy question. So then those first two questions when we are assessing validity were, did the review explicitly address a sensible clinical question? Well, yeah, it seems to, right? Does it adequately match our PICO question? That's another thing that we want to consider. And I think so, because we have the chronic pain in there, and that's what we're looking for. We have the same intervention. We want to see if there are benefits for pain for our patient. And that's just a reminder of what our PICO question was. And so I think that this journal article could be useful in our search for a treatment for our patient. So next we want to see, was the search for relevant studies detailed and exhaustive? And in that, we're going to look for a description of how they searched the literature. So there's a whole little section in there. It says identification and selection of studies. It says 28 databases and gray literature sources were searched with from inception to April 2015 without language restriction, because we discussed how perhaps limiting your search to only one language, like English, could cause some bias in the results. So it's important to really reduce the risk of bias. Oh, and in here it says the search results, they were independently assessed by two reviewers, and disagreements were resolved through consensus or referral to a third reviewer. So it wasn't just one person going through and using their judgment. It was more than one person seeing if they agreed whether to include those studies. And if the two reviewers didn't agree, then it went to a third reviewer to kind of be the tiebreaker. And so here's our flow of studies. We saw this in a randomized controlled trial. We saw how the population, their search strategy for who they were going to include in their study. And so this is kind of the same picture. We see the titles and abstracts screened, 23,000 of them. They excluded, based on whatever exclusion criteria they had, they excluded 23,249 of them. So then they looked at the full text of 505 of them, and they excluded this many of them. And we go down, and we finally see that 79 randomized controls were included in their systematic review. So they did do a detailed and exhaustive search. Next, we want to see, were the primary studies of high methodologic quality? So we're going to see an assessment. And down here we saw data collection and study appraisal. We found that randomized controlled trials were assessed for methodological quality using the Cochrane risk of bias tool. So they use that tool to see if one was considered a high risk of bias or if it was considered a low risk of bias, an unclear risk of bias as well. Risk of bias assessment was performed independently by two reviewers, and once again, the disagreements were resolved by a third reviewer, the tiebreaker. So they did look very hard for good methodology in the studies that they were including in this systematic review. And finally, were selection and assessments of studies reproducible? Again, there should be at least two authors evaluating the quality of included studies. And right there at the red arrow, we see yes, at least two reviewers were involved. And once again, as we said before. So what is your opinion? Based on the validity criteria, would you rate our article a strong study or a weak study? So after we have assessed validity, we have to assess the results. And when we're assessing the results for a systematic review, we have some questions that we want to ask. We want to ask, what are the overall results of the review? These may be presented in a forest plot. We want to check how precise were the results, and we need to look for a diamond in the forest plot for overall precision of results. Were the results similar from study to study? Did the authors assess for heterogeneity? So heterogeneity is the degree of variability between studies. So if two studies are studying the same thing but have completely different results, those would be pretty heterogeneous. And there's a couple of statistical tests that look at heterogeneity. And there's another one, I think there's like a Pearson's score or something, but right now we'll just look at the chi-square and the I-squared. So what are the overall results? So we're going to look at our outcome of interest. Our outcome of interest is pain. And so we see these are our results. Okay, well, what the heck does that mean? So we talked a little bit about odds ratio before and how to interpret it. These are a forest plot. So if the results, the mean and the 95% confidence interval, which this is the mean, is the little box in the middle. The 95% confidence interval are the whiskers. So if that entire thing falls above 1.0 or to the right of the 1, that means that it favors the treatment. So we have some studies here that favor cannabinoids. If, on the other hand, our 95% confidence interval and or our mean fall to the left of the 1, or if our odds ratio is less than 1, that means it either favors the placebo or it finds no benefit from the treatment. So when we're talking about odds ratio, we have to remember that odds ratio is a comparison between odds. So our odds ratio is the odds that an event will occur in one group divided by the odds that an event will occur in another group. So if we have our 2x2 contingency table and we have our disease or outcome of interest and our exposure status, we would plug in the numbers here of persons who have the disease or outcome of interest and also have had exposure to whatever beneficial or harmful thing that they're being exposed to. The number that have both been exposed and have the disease for outcome of interest goes right here in A. Those who have been exposed and do not have the disease or outcome of interest, that number goes here for B. Those who have not been exposed and do have the outcome or disease of interest gets filled in right here for C. And those who have not been exposed and do not have a disease or outcome of interest, the number gets put right in here for D. And so you can see, depending on the question that we ask, we can find an odds ratio. So in this case, we can find an odds ratio for the question, what are the odds that a person who has this disease or outcome of interest were exposed to this certain thing? So if we're asking that question, we are going to take our number in A and divide it by our number in C because you want to find the odds. And then you want to compare it to the odds that a person who does not have the disease or outcome of interest was exposed or not exposed to that particular therapy or harm. So that would be B divided by D. So we can also ask it the other way. We can say, what are the odds that a person who was exposed has this disease or outcome of interest? That would change our equation a little bit. So our odds ratio would be then, in that case, A divided by B. And all of that would be over C divided by D. But if you simplify this, once again, we get our cross products ratio, which would be AD over B oopsies, BC. Okay, so to find our odds ratio, it's just basically a cross products ratio, AD over BC. So when it comes to interpreting the odds ratio, remember if the odds ratio is equal to 1, that means the odds of exposure were the same for both groups. If the odds ratio is greater than 1, then those with the disease or outcome of interest had greater odds of exposure than those without. And if the odds ratio is less than 1, those with the disease or outcome of interest had lesser odds of exposure than those without. So if we go back and we look at our overall results for pain, we see that our outcome that we're looking for is improvement in pain. And we see if our odds ratio is greater than 1, then we see that those who were exposed to the cannabinoids had an effect of improvement in pain, whereas those who had an odds ratio less than 1, it means that a placebo worked better. So that's how we would interpret that. One more odds ratio example. We're going to use some numbers this time. And this right here is going to be our 2x2 contingency table. We are going to look at people who have had a heart attack and people who have not had a heart attack and their exposure. So right here would be, if I can draw a straight line, our 2x2 contingency table. Okay, and then up here, this is our number for A. So that would be people who have had a heart attack and who have been exposed to smoking. And this would be our number, whoops, I am all over the place with this pen, for B. This would be our number for C. And this would be our number for D. So we look and we ask the question, what are the odds of having a heart attack for smokers? So we want to see the odds. Our smokers who have had a heart attack is 14. Smokers who have not had a heart attack is 22. And then we find our odds are 0.636. What are the odds for non-smokers? So these odds are C over D. So this is 5 over 33. And our odds are 0.152. Then we find the odds ratio. So this is what we're looking at. We're looking at the ratio of the odds of having a heart attack for smokers to the odds for having a heart attack for non-smokers. So we take our odds for smokers having a heart attack, and we take our odds for non-smokers having a heart attack, and we come up with our odds ratio, which is 4.2, which means that smokers are 4.2 times as likely to have a heart attack than non-smokers. So next we want to look at the results. How precise are the results? So we're going to check for a diamond in the forest plot for the overall precision of results. So here's our forest plot again for overall results for pain. And we see these diamonds down here. And we want to check for precision. So what are these diamonds? These diamonds are kind of like the sum of everything that has come before. So in this particular chart, we have right here, we have tetrahydrocannabinol, and this is one category right here. We have one category here, and this is our result for that there. And then we have nabiximols, and we have a bunch of different brands of nabiximols. So this is all down here. And these are all the separate results for the separate studies in here. So we have all these different results, right? So for the tetrahydrocannabinol, we have, this would be our mean, and this would be our 95% confidence interval. It's very important to note that which side of the odds ratio line one the 95% confidence interval falls on. If this entire 95% confidence interval falls to the right of the one, then we can say that yes, we saw an improvement in pain with smoked tetrahydrocannabinol. Okay. Now, when we come down to nabiximols from GW Pharmaceuticals, we see our mean is over here on the left side of the one. And here's our 95% confidence interval right here. We see that our confidence interval crosses the line here. So our results there don't give us a very clear picture that this nabiximol either works or doesn't work with pain. However, the Johnson one, the mean and the 95% confidence interval fall completely to the right of the one. So that's pretty strong evidence that that particular therapy is favorable for the outcome, for the improvement in pain. So we see each of these individually has its own results. The diamond is a summary of all the results here. So this is our subtotal. This right here is the subtotal. The subtotal only pertains to the nabiximols. So this is our diamond. So if we're going to ask, do the nabiximols really, help or do they not help? Well, this diamond kind of crosses the line here. This is our 95% confidence interval, it kind of crosses the line. So the evidence is not 100% strong for nabiximols compared with tetrahydrocannabinol all the way up here, which falls all the way on the right-hand side of the one. But when we add in the tetrahydrocannabinol with the nabiximols, we see our summary result is this diamond here. And it looks like if we want to just put them all in one category of cannabinoids, we can say, okay, yeah, we can see that improvement in pain is seen with cannabinoids. Okay. So now we want to ask, were the results similar from study to study, and how perhaps the authors assessed heterogeneity? So we saw here that there's quite a bit of heterogeneity here in the nabiximols. Some show great favorability, some, all the rest of them cross the line. So the jury's still out on that. So we saw that the authors did assess for heterogeneity, and they assessed it using forest plots and the I-squared statistic. Now, we're not going to go into calculating these statistics, but we have some heterogeneity measures, and we can see the I-squared statistic is if the value is greater than 50%, then there is significant heterogeneity between the individual the results of the individual studies that were included in the systematic review. Our I-squared here is a little bit less than 50%. So the heterogeneity there is not significant. So they also give us a value for the chi-square here. And if it measures less than 0.1, then there's significant heterogeneity, and that's not less than 0.1. So we take what that information gives us, and we move on. And of course, we have to make a little joke about a forest plot. This is not what I meant when I asked you to make a forest plot, even though that's a very nice forest plot, if you ask me. Finally, we have to assess for applicability to our patient. So we have questions, of course. How can I apply the results to patient care? We have to ask, were all patient-important outcomes considered? Are the benefits worth the costs and potential risks? And we have to take into account adverse events. So our first question, were all the patient outcomes considered? Well, her important outcome is just getting rid of that unrelenting pain. And so, yeah, I mean, one of the outcomes of interest in that study was improvements in pain over placebo. Um, are benefits worth the costs and potential risks? So they also did studies of adverse events in this systematic review with meta-analysis. And then they broke it down into the types of cannabinoid. And then you can read this forest plot on your own. So, what I want to know is what did you tell the attending physician regarding what your research told you? So, that's something to think about. And this is our article reference. And that's it. I'll see you next time.